We'll try the Exponential New York Minute. So we have this 30 minutes to talk a little bit about the future of health and medicine and where technology can take us, how it's going to disrupt many fields from pharma to medical devices and beyond, and how you can leverage it into your own individual lives and those of your companies and employees. But before we sort of look into the future, I think it's often fun to look back to the future. And I had a chance to do that a couple years ago. I returned to Massachusetts General Hospital, where I did my medical training, both in internal medicine and pediatrics, for its 200th anniversary. So I had a chance to have a reunion with the house staff that I trained with when we were in the trenches, and joke about walking uphill both ways in the snow in Boston. And found myself, after one of the receptions, in one of the most famous spots of healthcare history. This is the Ether Dome, where in 1846, this very patient you see here is the first patient to get general anesthesia with a surgery. Before that, they literally bit the bullet. This picture's clearly before HIPAA privacy laws. And if you go back to the Ether Dome today, it's pretty much like it was in 1846, frozen in time. You can see the actual sponge from the case in the back room, and it's a shrine to history. I wandered down the hall about 4 minutes away to the ward where I spent my month as a brand new intern, young doctor in the mid-90s, and to my shock and dismay, that was also frozen in time. Some of the same alarms were beeping, a little PTSD, some of the same nurses, some of the same patients. Only difference was the poor intern on call was pushing around a 8-year-old laptop, had to type an electronic medical record, print it out, put it in the paper chart. And the front desk there is still faxing pharmacy orders to the pharmacy 2 floors below. Fax machine, still the epitome of healthcare technology. And my thought was, even in Massachusetts General Hospital, great institution, healthcare is still being practiced like 1846 in old silos and old definitions, in old departments and in specialty buckets, and holding on to information. And we're in this new exponential age, connected age, digital age, genomic age. We can think out of the box of being, an hour in the waiting room for a 10-minute visit in new ways, and think outside of the traditional bucket of body parts and specialties as we look into the future of healthcare. And we're going to need to be innovative in leveraging these technologies if we're going to address some of these challenges, from our rising costs, the demographics with 10,000 baby boomers turning 65 every day. No matter what you think about Obamacare and accountable care, we have many new covered Americans, but there was a huge actual shortage in primary care physicians and specialists in most parts of the country. We're in this era of big data, but it's not often useful small data, actionable information we can use at the point of care. And a lot of that information is still fragmented, half on electronic paper records, half on paper. And of course, innovations, many of which are here and we're learning about today, are very exciting in the cusp of touching all of us. But in the healthcare world, we have our friends, the F words at the FDA, who don't often appreciate the power of exponentials and how to use those, and our friends, the payers, who don't often know how to value and pay for these. So just a couple points on the cost side. We're at 18% of our GDP now, right? Though 17th in the world in terms of outcomes. If we can shrink that bucket, that has huge implications for our economy and our ability to spend in other arenas. Two meta-trends are impacting healthcare across the spectrum that have implications in finance and beyond. One is, where do we spend our dollars? Most of it today is on sick care, not healthcare. We spend 80% of our dollars roughly on the 20% of folks who are already sick and have chronic and advanced disease. We're starting to shift the curve to the left to incentivizing prevention and wellness, and aligning the incentives for patients and doctors alike and systems to do that. Another meta-trend is, where's healthcare happening? It's traditionally in the hospital, the ICU. That's where you go to get your lab tests and numbers done. More and more of healthcare is coming out of the hospital. We don't want patients to even be admitted in the first place. And when they get discharged, they go home sooner. And so healthcare is coming to our homes and increasingly onto our own bodies. So as we look at where healthcare can go, it's sometimes, the theme of this exponential conference essentially is how fast health technology is moving. I watched the Steve Jobs movie for the first time a month or two ago, and I was shocked at the opening scene. Steve Jobs' character is waving around the first, iPod, and it was 2001. I was a first-year fellow at that point, and clearly iPod's progressed. It's only been 6 years since the Android and iPhone technologies have come out, and they're obviously writing Moore's Law. But it's not just the Moore's Law component, or the 3D printing, or the social networking, or all those things that are exploding. It's where they converge, and where we can match them up, that enables us to reinvent things in any field, including in healthcare. Just like we've seen the reinvention of how we read books and how we see companies go bust like Blockbuster, how we don't go to travel agencies anymore. Uber, as we've been hearing about today in the news, didn't invent the mobile phone, online mapping, online payments. They just bundled it in smart ways. So what could be the Uber of healthcare that can be as disruptive in that realm as we move forward and take some of that 30% of the cost outside of which is inefficient cost today moving forward? Pharma, big area that's ripe for disruption. Still takes them 10 years and $1 billion per drug. Lots of room for improvement. So you just heard from Raymond about the incredible pace and speed of human genomics. And we're at the point now, as you heard of, basically a $1,000 genome. I've had my exome done. Some genetics can be done, obviously, for $100, spitting in a tube, dropping it in the mail. Though 23andMe has been in some trouble with the FDA. When Raymond comes to me with his genome on a disk drive, and I'm his doctor, I still don't know what to do with that. We still need to know how to mine and pull that together and put it into the workflow of the clinician and the patient so it's useful. And it's not just the human genome that's moving exponentially, the human proteome, thousands of biomarkers from a drop of blood, environmental exposure, the idea of an exposome, imagery data, biomarkers, the microbiome, the ability again to sequence the bugs in your gut and use that potentially for therapy, whether it's a fecal transplant for curing inflammatory bowel disease or maybe even treating obesity, or this is some new technology coming out of bacterial soap that, no more showers for at least once a month by treating, and this might be disruptive to the, soap companies. Those things are sort of coming along faster than we might imagine. Now, with genomics, we think about personalized medicine, but it's really much more personalized and precision-based medicine, or more so, this idea often coined of systems medicine and P4 medicine. Predictive, most folks will get sequenced, maybe even at birth. You can see the movie Gattaca to get an idea of what that means. Preventative, so the preventative steps are based on your genome. Personalized, not everyone benefits from aspirin, for example. And the most exciting part today in this connected world is participatory. We can start unsiloing some of these elements of healthcare and using them and sharing this data, whether it's the amazing ability to image a patient and reconstruct that data on your tablet, which used to take weeks or months of data crunching, and that makes us smarter with interventions. It's with higher speed imaging, we can now really start to understand the brain in new ways, not just the incredible anatomy, but increasingly the connectome, which plays a role in normal processes, depression, psychiatric disorders, autism. We can now, with the power of high-speed imaging, even literally reconstruct what someone's watching while they're in a scanner. So brain reading is possible. You have to be in an MRI, so it's hard to sneak that away. But this is on the cusp of really changing how we understand the brain. And where that gets important in terms of our cost and our economies with the aging population and the incidence of Alzheimer's. What if we can now detect Alzheimer's 10 or 20 years before it becomes clinically evident? This is a new scan from Lilly. We can pick up the plaques 10 years earlier. That's with a scan. You can actually do eye tracking on a $10 laptop or a $10 sensor on a laptop, watch someone's eye movements and predict who's going to get Alzheimer's 10 or 20 years later. Which means maybe we can be proactive and do therapeutics early on those folks before they become clinically affected. How about the world of cardiology? You all know the interventional angiogram for doing diagnostics of your blood vessels. That field's being disrupted by the convergence of high-speed imaging, sending the data of a CT scan to the cloud, and now reconstructing the patient's coronary blood vessels to determine, do they have a narrow blood vessel? Does it need a bypass or a stent? If so, if we put in a stent, how it would affect blood flow? Maybe we'll 3D print that stent at the point of care and won't need the chain of supply that is the standard in the device industry. So that's moving quickly. That's technology out of Stanford. Another Stanford spin-out I advise called Morpheus can do a 6-minute cardiac MRI, reconstruct not only the anatomy, but the physiology of the heart, completely replacing the data from an echocardiogram and giving you that data almost immediately. So lots of things are moving in that realm, not just the imagery, but the ability to converge on top of that focused ultrasound, truly non-surgical surgery, which is knocking out uterine fibroids, and soon might be applied to metastatic tumors that could never be resected normally. So that's some exponentials at play in the imaging world and beyond. Exponentials, of course, are in our pockets. With the smartphone of 10 years ago, it was basically a Palm Pilot. And now it's only been 4 years, actually, last month that the iPad came out. 80% of US doctors bring those to work with them, whether the IT department wants it or not. Every medical student gets one at Stanford loaded with their curriculum the first day of school. And now we're in an era, essentially, of the cheapest Android tablet on the market. It's $35 being sold in India. For $35, you can give this away to your patients for less than the price of most prescriptions and could be part of education, public health, many ways. And this is not the fastest Android, but in a couple of years, it'll be the equivalent of today's Samsung Galaxies and beyond. So Peter mentioned the dissolution of technology. This sort of idea is starting to happen into healthcare as the technology that used to be separate, a glucometer, now is integrated into your smartphone potentially. When you have integrated data in the hands of our patients, they become empowered, they become engaged. You have a feedback loop, whether it's blood sugar data to help tune a diabetic. You don't even actually need to have a connected glucometer. You might prescribe an app to a patient, incentivizing, gamifying them, recording their blood sugar, and sending those data back to the doctor, who's also incentivized to optimize their oral medicines for diabetes. In this case, they drop hemoglobin A1C by 2 percentage points. That's bigger than any blockbuster drug. So we're entering the era of prescribing drugs, prescribing apps, as opposed to just drugs and devices. The question is who's going to pay for them, who's going to regulate them? And we're taking lessons from other well-known industries like OpenTable for making restaurant reservations, and the most highly valued healthcare IT company based in New York take that model and it's made an OpenTable for doctor appointments, ZocDoc, over $1 billion valuation. I used this for the first time about 3 months ago. I had a small little lump on my neck for a couple of years. I knew it was pretty benign. I didn't really want to go see a dermatologist, so I downloaded an app called iDerm. Paid $12, had my little picture and story analyzed. My remote dermatologist said probably a benign cyst. So I went on ZocDoc, found a plastic surgeon who had good ratings down the street from me in Palo Alto, filled out all the forms that are on the phone in 5 minutes, sent him my diagnosis, and went there. And my first visit, boom, here's my case, here's my lesion, here's the surgery, here's the pathology, everything was fine. All done with basically 2 apps in one visit, and lowered the friction and improved the engagement and probably lowered the cost of that opportunity. Now, clearly, there's an app for that in many elements of healthcare. There's thousands for almost every type of specialty and clinical need. Some of them are junk. Some of them are very powerful. Some are integrated, like iTriage, which is actually bought by Aetna, for example. So the payers are starting to getting involved. They can start engaging with their consumers in smarter ways and helping them be more proactive and lower their healthcare costs. We're seeing simple apps, like the Walgreens app, potentially has made the most money of any app on the planet, billions of dollars, because those who use this app are much more on top of their meds and their refills. And so Walgreens makes dollars from that, and hopefully the outcomes are better. So simple elements, Appify can make a huge difference. Gamification, again, engagement. We're learning, from tools from Angry Birds to make health games. There's at Hope Labs, we had a game for our pediatric cancer patients at Stanford where they'd shoot their tumor and raise their white counts and stay more on top of it. We're seeing rewards coming to our patients, lowering their premiums, just like better drivers with black boxes in their car can pay less. We'll see that start to happen and incentivize better behaviors. And we're taking off-the-shelf technologies, which used to be magical $1,000 technologies like Microsoft Kinect, which is now $100 and has been hacked to use in the operating room for physical therapy, something folks most don't like to do, and can make it much more engaging, fun, and integrated. So lots of ways to take off-the-shelf technologies, including Leap Motion, which many of you may have seen, which will change the way we interact with our devices, but can be used by a surgeon in the operating room to manipulate elements, or someone with disability with just a little finger movement to interact with the environment. Now, this age of connected health and mobile health, it's often termed digital health. All this information is coming from paper to digital realm, and that means we can start to use the big data elements and the analytics. And with the smart devices now attached to our mobile elements, we can be an engaged consumer, patient, or physician, whether it's an eye exam mediated by an attachment. This is from MIT Media Lab. On the lower right, if you have kids with ear infections, you can maybe snap on this attachment to your mobile phone and look in their ear, which is useful in many modalities, and that will save a doctor's visit. Now, hopefully, the pediatrician's paid for that visit. That's part of the issue. One of my favorite examples on the lower left is the EKG phone case. This was invented by my friend, Dr. Dave Albert, and essentially what that enables you to do is use the smart case, if I can only find my right app amongst all this, to case on my phone. I basically hold the phone, and now I have a live EKG directly on my phone that can be sent anywhere on the planet. And if I'm a patient with a heart condition, or I'm a nurse or a paramedic, this can be used. If I pass this around the room, I'm sure we'd find someone with a heart block or some other condition they didn't know about. And this I've used when patients have collapsed on a plane or a party. And those of you who don't read EKGs actually can just press a button on the app, pay $10, and have that EKG analyzed and sent to you and to your clinician. So incredible power to bring point-of-care diagnostics in your hand. Point of care is coming to our youngsters. I have a 1-month-old at home. There's connected diapers coming. TweetPee was just launched by Huggies, so that might disrupt some elements. We're seeing that for number 2 as well. This is the New York Times. So there's new ways to get data from unpleasant places. This is part of this era, what's often termed quantified self. How many folks here have a Fitbit or something similar to a Fitbit? A bunch of you, right? I'm wearing 4 of them right now. I don't usually wear 4, but these are all now technologies that have started out measuring our steps and sleep, but are moving forward from scales that tweet our weight to, in this case, a watch made by Basis that tells time. It even tracks my steps, my calories, and my heart rate. So if I was a cardiac patient, I could use this potentially to track my cardiac meds. This was just bought by Intel, by the way, for $110 million. It was a 4-year-old company. You know that Apple's getting in the game with rumored iWatch, and as they just announced last week, this health kit. So a lot of these disparate technologies that might be in risk can come together and feed back to your doctor in an integrated way. So it's going to be very, very powerful, particularly with consumer companies like Apple, Samsung, and Galaxy all moving forward. So watch the watch space, an incredibly rich spot for healthcare technology to evolve. And simple diseases like hypertension. 1 in 3 Americans has high blood pressure, but less than half have it well controlled. A connected blood pressure cuff you can buy in an Apple store on Best Buy for $60 can give you much more insight yourself and for your healthcare team as to how to tune your blood pressure medicines as you go forward. tracking asthma, all sorts of new realms to get data and make it actionable. And again, these technologies are starting to disappear. These are moving into our phones. We're seeing patches evolve that can measure our vital signs. So for example, I'm wearing a $2 disposable patch developed by a company called Vital Connect in Silicon Valley. I'm wearing it under my shirt. Maybe we can switch to the live stream, please. You're going to see my live EKG data coming through this patch, talking to my phone, talking to the web, and anywhere in the world you're logged in, you can see my vitals. Like, all right, it's 126. Stress is only 99%. Thanks, guys. If I move around, you can see my steps, my posture. If I fall down, it can detect that I fell down. And if I don't get up, it'll call my mom or call 911, right? And this is all available, I think, within a year or so for both consumer and the clinical endeavor. But of course, the doctor doesn't want to see this data streaming at them all the time. We need smart sensors and filters on this data as well. If we can switch back, please. So it's, again, not just wearables. We're moving to this era of even insidables, a term coined by my friend Lucian Engelin. This eye pill, for example, is a swallowable camera. It's integrated exponential technology you can swallow and look at your GI tract, for example. So we're going from wearables to insidables. Now, the clinician-doctor bag is going to improve. We have a bunch of tools now. I've got some of them in my pockets. There's now tools for almost any type of consumer activity, from sports balls that'll track your kicking to swing. There's the long tail of these that start as, again, consumer devices, but they're moving more and more medical, from posture to blood pressure sensors. And the challenge is, how do you make sense of them? So I just co-founded a company called Bionic Health, where part of what we're doing is enable people to own and share their data, as well as find the devices and technologies that match them and compare them and share them and even prescribe them if you're a clinician. So part of this new era will be prescribing devices, apps, and services as we move forward into the new era. Now, no one wants to be logged into all these devices, and it's not just, again, the vital sign piece, it's also our blood. We're now at the point now of point-of-care diagnostics. Microfluidics is taking what used to be, 10 mils of blood can be done in 1 or 2 drops and analyzed, whether that's malaria in the developing world, or now just simply something as simple as urinalysis can be done at the point of care. This is basically urinalysis on a dipstick with a QR code. So you take a picture of the app, it can give you a very accurate urinalysis in real time, or you spit in this little tube on the right, and you can test yourself for influenza or bird flu. So simple ways of getting powerful data at the point of care are shifting how we are connected and bringing us to this era of connected sort of digital checkups. The idea that you can have your vital signs, your lab data. You can then, for $10 now, or $20, there's about 4 companies launched last year doing telehealth on your smartphone. So you can find the specialist, a primary care doc, anywhere you have connectivity, and that is going to be disruptive to many of elements of the healthcare system. I think in 5 years, half of doctor visits will be mediated through some form of telemedicine. And I hope, as a clinician, that doesn't get between the doctor-patient relationship, but can start to engage us and give us more touch points and enable it in smart ways moving forward. Now, of course, all this in healthcare, again, like many fields, is the layering of these technologies, which has positive and negative sides. The new pacemakers are smaller, can be implanted by almost any clinician. They have IP addresses. So you might have heard the fact that Dick Cheney turned off his pacemaker connectivity because he was afraid it might have been hacked. Might have been a good thing, depending on your political persuasion. But you'll hear more from Mark Goodman about hacking pacemakers and insulin pumps. There's a dark side. Or who owns the data from our own bodies? Medtronic made this implantable defibrillator, but for many years wouldn't give the patient his own data. He was an engineer. He wanted his raw data. Who owns the data from our bodies? What if we share it and unsilo it? And then again, part of the theme of what we heard about today with AI and beyond, how do we get smarter as clinicians and as patients and as employers about managing this information and making it useful? So we heard from Neil about artificial intelligence. That's often threatening to doctors. AIs are going to replace us. So I like to think about it more as IA, intelligence augmentation, which is what Dr. Watson is sort of doing now. It's starting to augment our abilities to make smart diagnostic choices, smart therapeutics, how to staff our hospitals, how to do better clinical trials. And as that comes together, the science fiction realm is integrating. The Star Trek tricorder is essentially reality today. We have $1,000 ultrasounds that fit in our pocket. That used to be $100,000 carts. And I've been involved with XPRIZE, which Peter founded, advising the healthcare side, and we helped develop a medical tricorder XPRIZE that you've heard about already. And it's impressive how many teams have entered, over 200, I believe. One of the leading contenders started at Singularity University at our first FutureMed program called Scanadu. They've already developed a tricorder, essentially. Hold it in your hands. It talks to your smartphone, measures your heart rate, your respiratory rate, your temperature, blood pressure, et cetera. Talks to your smartphone, is infused with analytics that know you and can communicate that back to your healthcare system. And this isn't science fiction. The FDA has worked with them, and 10,000 of these are shipping as part of a clinical trial next month. Now, of course, it's not just the technology, it's the design thinking. So I introduced Scanadu to the design from IDEO to look at where this would come together in the next couple of years. We made this short little movie. Take a look.
Technology has given us an unprecedented window into the human body. But on a day-to-day basis, we're still in the dark about our own health. We are changing that.
You okay? Do you feel okay?
What if instead of fearing the worst when you notice something out of the ordinary, you could identify the condition yourself? Getting the right diagnosis would save you worry
It says it's roseola.
and an unnecessary doctor's visit.
Rest at home, it's okay.
No problem.
Instead of hearing about a viral outbreak on the news, imagine you got an alert that was tailored to your family's needs. It would also give you advice about what to do next. What if you had a way to identify what was wrong right away?
It says it's 103.8.
A way to get all of the information you need to understand the situation. And in serious cases, you would know when and where to seek help.
It recommends taking it to urgent care.
We're building a way for people to check their bodies as often as they check their email. It's all possible, and it's only the beginning.
Most of you check your email 150 plus times a day, so the hypochondriacs are in trouble. But this is, again, crowdfunded, actually. They broke the record in Indiegogo, $1.6 million, and then 10,000 of these will ship in the next few months or so. And again, as we pull this data together, we can start to make sense of it, right? Just like our cars, we know more data about our cars with 200 plus sensors than we do know about our own bodies. What we care about is the check engine light going on. It's from multiple sensors. It's the integration of that. So this idea of Internet of Things will come to the Internet of the body and our environment and give us that equivalent of that check engine light. And bring us to this era of connected health, where it's not just the individual's data, but it's in system mode. We understand that we can start to share this. And more folks than you think are happy to share their medical data and leverage that into the social network. If you understand the social network of a patient, you can make a much better job of leveraging their behavior change. Because it's our behaviors, much more so than our genetics, that are impacting our health and our long-term costs to society. So there's new companies, for example, that are disrupting how we prescribe behavior change. Amada Health has a system for getting pre-diabetics, folks on the cusp of becoming expensive diabetics, to turn around and not become diabetic. We're seeing new ways of using augmented reality to see future you. You look in the mirror, future you, yeah. What if you keep having donuts for breakfast? There's future you, right? And you don't need to wait for that virtual mirror. You can download apps today. Here's me now. Here's me 1,000 donuts later. I'm like, oh, I'll hold off on the donut, right? Or if your kids are spending too much time on Facebook, or folks are smoking, you can show them what their skin's going to look like. Here's the Facebook example. So things like Oculus Rift, which can fool our brain, which doesn't know the difference between augmented and real reality, can be very powerful for behavior change. We're seeing robotics play a role. Telemedicine, you've seen telepresent robots outside are starting to come into healthcare so we can augment our rounding in hospitals, and there's now low-cost versions you're seeing for $1,000 coming out. Robotics is playing a role now in the operating room, more and more ability for the surgeon to have augmented skills. And in some cases, robots may replace and disrupt, for example, the anesthesiologist. J&J came out with a robotic anesthesiologist. You can think who's fighting that tooth and nail for getting into the clinic. So that's being disrupted. Robotics is enabling the disabled in many ways. We're in the era now of brain-computer interface. Small surgical incision puts a little chip on the motor cortex of a woman who's completely quadriplegic. And now just by thought alone, like move my hand to the right or left, she's able to control a three-dimensional robotic limb. The next stages will be to rewire that back to her own arm. And that's incredible brain-computer interface technology. But it's coming to the consumer. We don't need to wait for that element. I'm wearing right here I won't put it on, but now it's being sold for a couple $100. This is the Muse headset, which can be used to measure my brain waves. I could prescribe this for meditation, for anxiety, for depression, for ADHD. Kids who are using this sort of technology can see their data. Here's my data when I was chilling out versus not chill. And that can encourage mindfulness and better outcomes in many fields as well. So BCI is moving quickly. And robotics is coming to our own bodies. You heard from Avi with 3D printing, the incredible example of exobionics and 3D printing components of that. The challenge still is, and this is Hugh Herr's technology of MIT, who's going to pay for some of these? This technology enabled the woman, the dancer at the Boston Marathon bombing, who lost her leg to dance for the first time at the TED conference, but Medicare isn't yet reimbursing it effectively. So there's lots of challenges in the payer realm, but incredible opportunities as well. Of course, we don't want to just treat spinal cord injury with exoskeletons. We want to cure it. In the world of regenerative medicine, the stem cell world, which I spent the last decade in at Stanford, is getting exciting. The man on my left won the Nobel Prize in Medicine for developing induced pluripotent stem cells, the ability to take any one of your skin cells and turn it into your own stem cell line. And that is blending with the world of 3D printing. You've heard some great examples from Avi in orthopedics and prosthetics, the ability to maybe even print, now some companies doing hips and knees and printing the parts in the operating room. So again, that might disrupt device companies and their supply chain. You can scan, for example, me and make a mini-me. That might be useful in a patient who's lost part of their face from cancer. We're blending that with biology, printing cells instead of just ink. And we're in the early era of making simple organs, but that's moving to more complex ones like solid kidneys, livers, and beyond. That's used for clinical trials today, screening drugs, but we'll move into the clinic, I think, in the next 10 or 20 years. So I've been fortunate to chair the medicine track at Singularity University, and at our summer programs and our executive programs, a lot of folks love the healthcare space, from using drones to deliver drugs and vaccines to making telepresent gloves that will enable, enable clinical exams. And since we had so much interest in the healthcare arena, we started a program 3 years ago called FutureMed, which we've grown from being at NASA to be called Exponential Medicine, and now it's being held at the Hotel Del Coronado in San Diego. And I'm hoping some of you can come join us there this fall for an exponential examination in more depth. Okay. Part of the theme of Singularity U and exponential medicine and exponential finance is all the new players coming into these fields, whether it's companies like Google now that are getting into longevity, or the government, which is releasing new data streams. There's health hackathons happening. They're encouraging designers and design thinking to come into the mold. So design thinking, we can now rethink some things as simple as canes, but also take design thinking all the way forward into the world that we take from aviation, which has a lot of design thinking in it. And I'm flying to London tonight on a jet. Hopefully my jet has a smart system around it. It's not just a jet. We can take lessons from that realm and think about it in healthcare. I've been flying since I was 20, and I've been a flight surgeon for 15 years. And we can take lessons from this flying world, not just Cessnas, but fighter jets. And I've got hundreds of hours in fighter jets now. And what do we take from flying into healthcare and other fields? Well, the idea of checklists have made flying safer and the operating room safer as well. So we're now implementing checklist regimens and apps that can help track a procedure both at home and beyond. We're seeing examples, and by the way, I think my clock started 5 minutes less, so I think I've got 4 left. I'm going to take it. Simulation is changing the way we do training, not just for pilots, but for our medical students and beyond. So we're stressing teams to fail on learning from simulation. We're learning from the world now of radar and heads-up display. The cockpit environment's gotten much more data-intensive. Now it's becoming glassified. We're seeing data in new ways, just like Johns Hopkins is working with Lockheed Martin to make new intensive care units. We're seeing that meld into the world of heads-up display from the fighter pilot world is moving into the world of the surgeon and beyond. So we can see data in smart ways. And just like we're doing in our modern cars, that's affecting our driving behavior. And the last, and how we see this data can change. We want a GPS for healthcare, right? Not too much data, just enough to say, Daniel, go right to the gym, not left to McDonald's. All right. Last thing I'll mention is, using technologies like Google Glass, which have definitely come into the fold. The best use case, I think, to date is in healthcare. We're seeing the most innovation happen on this platform in the healthcare environment, not just for the patients, but for surgeons, mostly to see data, to pull in electronic medical record data immediately, pull it at the point of care right when you need it. In my last minute, I'll just give one last example. The idea of, and we'll skip through this, because you might see your breakfast differently before and after in the future with these technologies. That might change your behavior, particularly when you get warning. And this technology is now, again, moving to our schools and medical students, is radar. This idea of crowdsourcing the big data. What if we could take the idea of maps and mission control from the flying world and take it from the world of Google Maps to sharing our own healthcare data, unsiloing it in smart ways, sharing it with each other, and learning as we go. We share a little bit of privacy, but we move forward. So I think the future of healthcare is the integration of these exponential data sets, the understanding of our social networks, our local environments, so that I can tell, for example, where the influenza is happening. I can mine Salim's social network and determine, should I shake hands with them that day or not? That's all actually available information. I can have dashboards for my company, for my hospital, and I think we'll move to an era where we're much more contextual and much more importantly, using design thinking and all this integration to move us from an era of episodic and reactive healthcare, we go to the hospital after we have the issue. We can get our data intermittently to an era that's much more continuous and proactive. So I'll leave you with the thought of thinking exponentially in healthcare. It's going to shift many industries, how you might want to invest, how you might want to leverage that information for yourself as we move forward, because it's not for us just to predict the future in health and medicine. It's for us to go out there and create it. So with that, I'll say thanks.